Thank you, Adam, for that generous introduction, and thank you for joining us tonight. It's a great great number of people here this evening for a talk on OCTA and glaucoma. So it's a privilege to be able to spend some time with you this evening. So there are a lot of ways to reach out to me if you want to continue the discussion. All of my slides tonight are found on MikeCymbor.com. So if you have any questions about the slides or you want to dig in a little deeper, then feel free to access those. Send me an email, reach out to me through all the different various media, social media sources, and I'm always happy to engage and carry on the discussion. Greetings from Nittany Eye Associates in State College, Pennsylvania. We are a large ophthalmologic practice. I am a true glaucoma specialist. I've been in optometry probably 27 years, and for about 20 of those, I was a primary care optometrist with an interest in glaucoma, and I still do quite a bit of primary care, but I do have a true glaucoma subspecialty. So where I'm coming from tonight is that type of experience in deep with glaucoma, and I've been using OCTA for probably 5 years, maybe 6, and so I'm really excited to be able to share some of my experiences with you tonight. Much of my glaucoma knowledge comes from the Optometric Glaucoma Society, and so it's a real honor for me to be a part of that. And if there's one meeting that I will not miss every year, it's the OGS, and so I'm excited that we're less than 2 months away from that coming up at the Academy. So tonight we're going to be talking about advanced diagnostic and enhanced glaucoma patient management and outcomes, how we can use both the Solix and the OCTA function to maybe manage glaucoma in a slightly different way than we currently are. This whole talk stems from this question that came up maybe 5 or 6 years ago in a conference, and we were having a discussion. If you could pick one instrument for glaucoma management, what would you pick? And some people yelled out tonometer, visual fields, all these different things. But I think as time has gone by and this has evolved, and we could add ORA to the mix. All these different types of glaucoma instruments, but easily OCT would be that in our practice. And so that's why and to watch OCT evolve as the years have gone by, now having OCTA capabilities and watching the resolution just get better and better and better. So it's fun to see where we've been, but also where we are now and where we'll soon be going in the near future. All right, so there are many choices out there, and so I know that in fact, in our office, I'm using several different OCTs. Our flagship office, at any given time, we have 5 or 6 optometrists all at the same time, one ophthalmologist, and so we are a busy place. We have a lot of instrumentation, and so there are many choices out there. But what do I want in an OCT instrument? I want easier to use for technicians. I want easier diagnosis. I want best-in-class OCTA with metrics, and I'll explain what that means. I want best progression analysis, better with advanced glaucoma. We know in advanced glaucoma we often hit the floor, and then what do? Well, we're left with visual fields, and we know as the glaucoma becomes more advanced, monitoring visual fields primarily, there's so much variability and unreliability at that stage, but that's in the past has been the best we've got. So give me something in advanced glaucoma that can do a better job. And I want edge-to-edge angle scans. And so these are the things I want as a glaucoma specialist. I know many of you want as well. So ease of use, and I will first say that I would not know how to run an OCT myself, but I have amazing technicians here. Here are 2 of them, the Thing 1 and Thing 2, Abby and Kim, and so I have to rely on them to get amazing scans. And so I want something that's as easy for them to use as possible. And so when we have a conversation about the Solix instrument and how fast the scanning speeds are, they come to me and say, oh yeah, this is much better than previous generations or other OCT instruments that we may have in our office. And so take it from thing one and thing two, not from me, that it is easy to use. The Solix is very easy to use. Now let's move into the next section, and I'll illustrate my point with a case. We have a 59-year-old referred from one of our local optometrists. Again, we are a glaucoma referral center. Tmax 21 and 20, central corneal thickness 556, 547, corneal hysteresis 10.1 and 11.0, no family history, blood pressure 139 and over 87. So we use the Hogstrite octopus in our main office, and you can see that this is this is more than mild glaucoma based on the fields. Looking at the nerves, we can see infratemporal, and you can see, I'm assuming you can see my my cursor here. And if that's not the case, please let me know. And in the left eye, we see infratemporal thinning as well. We also see a transheme. And when we look at the arteries and veins, we can see there's quite a bit of attenuation there. And so here we have our Solix report, and there's just so much information, but it is on either one or two or sometimes three screens. I know some of the instrumentation that we've used in the past have required 8 reports, 9 reports, sometimes even more reports, but pretty much in three to four reports from the Solix, I can get so much information. So I'll just kind of walk through all of these things here. And so, we have the en-face image, and in that we can see the nerve fiber layer defect infratemporally. We can see how it compares to the database. We can also see the ganglion cell complex, how thin and dark it is in this area. We can see the nerve fiber layer analysis, how it's reduced here. And a lot of times, there's a lot of other instruments that can give you that. But here's where the Solix goes a step further. Now we can see OCT-A, we can see the angiography. And not only do we see, oh yeah, right where we see the nerve fiber layer defect, we see reduced angio, we see reduced vessel density in that same area. So we can have full confidence that, yeah, this is a true nerve fiber layer defect, and yes, it's affecting the blood supply. There are several studies that indicate we're going to start seeing this before we see it over in the en-face image or clinically. But also we have metrics. So not only do we have metrics for nerve fiber layer and ganglion cell complex, which everybody has, but we also have metrics for OCTA. I can see the vessel density percentage. I can see superior and inferior. This type of asymmetry is very, very common in glaucoma, and we see that 51% versus 42%. But I can even go a step further. I could look in it in all the different quadrants. And so the beauty of OCTA is not being able to just eyeball it and see that, yeah, there is reduced vessel density, reduced perfusion in that area, but we can also look at the metrics and see what the vessel density percentage is in a number. And that also, we can also measure that as time goes by. In the left eye, we see a similar thing. Infratemporal nerve fiber layer defect, variation from from the database, infratemporal thinning, all this thinning here. And yes, in the same area that we see the nerve fiber layer defect, we also see reduced vessel density with an asymmetric metrics on angio. So just a ton of information on that screen. And I'll look at the second screen. This is more, this kind of goes a little deeper into the ganglion cell complex. and the vessel density of that. And again, we kind of saw this on the last screen, but now we can really dive in and say, okay, yeah, it affects more the superficial layer. The deep layer is not quite as affected, and that's also common in glaucoma. All right, so with some of the other units that you're using, you can really get OCT report overload. I know I've been a victim of that in the past, but having the Solix reporting gives me a lot of information on very few reports, and I really appreciate that. So in this patient, we're going to confirm the diagnosis, moderate stage open angle glaucoma, and I will say that we also differentiated open angle versus closed based on our angle scans, but I'm going to illustrate that a little deeper into our talk this evening. We're also going to make the diagnosis of hypertensive retinopathy, not diagnosed nearly enough by our colleagues, and we're going to perform SLT through the Glaucoma Institute in our practice and control this glaucoma that way. So you can see how easy it was to confirm that diagnosis, and just a lot of information in a single report. Here's a few other examples that and you can see here just the nerve fiber layer defect, nerve fiber layer with the deviation from normals. We can see how the nerve fiber layer is affected. In this patient's case, not only are we seeing infratemporal reduced angiography, but supratemporal and a little bit supranasal as well. And so again, the analytics 41 and 38, this is a little more symmetric, but if we kind of parse it out even into the quadrants, we can really see quite a bit of asymmetry there. Next example, infratemporal nerve fiber layer defect, supratemporal here. The en face image is just very clear. We see nerve fiber layer thinning, ganglion cell complex thinning, and again, we're seeing this big, this large vessel density reduction, reduced perfusion on angio, and going into the analytics, 48 and 37 difference. So a really large difference there on angiography. Again, really classic for glaucoma. In the left eye, you can see, at a glance, it's just, beautiful how we're able to see the reduced vessel density on these reports. Still another example, infratemporal thinning, quite a bit of vessel density asymmetry. In fact, superiorly, we're actually looking pretty good, but infratemporal, the most common area, infratemporal damage in glaucoma, we all know that. We can see over here how thin this nerve fiber layer defect is. We can see how it goes right across the ganglion cell complex, across the raphe, and look how that just jumps out at us on angio. And looking at the analytics, superior and inferior, it's not all that different because this is such a small area. But when you break it down into quadrants, you can really see the difference between 48 and 40 is very significant. And so having the quadrants and the hemifield on vessel density, the OCTA metrics is really beneficial to me. So give me best in class OCTA and give me the metrics. I don't just want to look at the picture. I love the pictures and I use them all the time in my management, but I also want to see the metrics. And that's really what unique with the Solix from Visionix. OCTA in general, I borrowed this slide from Austin Livereth, and he, he's with optometric management and an optometrist who just writes amazing articles, great lecture. But I borrowed this slide from him, and he kind of said, when OCTA came out, we're really good in the glaucoma space in optometry and ophthalmology at looking at the tree. We can look at at what we, what we can obviously see, but are we as good looking a little deeper at the root system in some of these blood vessels? And we're seeing things deeper that are really, really meaningful in glaucoma. In the same way that a lot of times a tree is going to look great, but if you, start digging and look at the root system, you're going to see disease sometimes here before you're going to see it here. And I would contend that in glaucoma, it's a very similar thing. So now I understand your skepticism. Spock had a lot of skepticism. And so I hear this over and over again, in the exhibit halls or in lectures when we talk about glaucoma and OCTA. I'm really skeptical about it in the management of glaucoma. And I'll hear things like, yeah, the research doesn't really bear it out, or we're not really sure what to do with the information, or we're not really sure how to use it. And so the thing I would, I would contend is, what does the American Academy of Ophthalmology have to say about OCTA? And this was a study that came out in 2021, all right, so 3 years ago this came out, and I'm going to be very fair in my assessment. Of course, this talk is sponsored by Visionix, and I appreciate their willingness to bring content like this to you, but I want to be very fair in my analysis. So I'm going to talk about the AAO report, both the good, the bad, and the ugly. So the good is this. Here's their conclusions from the study that I just referenced. And again, if you want to go back and access the study, or you forget where the reference was, go to my website, look in the slides, and everything is there, so you can kind of read up on your own and dig in a little deeper. But their conclusions back in 2021 is OCTA angiography can detect changes on OCTA with suspected glaucoma, pre-parametric glaucoma, and parametric glaucoma. We know with parametric glaucoma that there's a lot of damage, and a lot of the examples I showed you had a lot of damage but I use those for illustrative purposes. But in both pre-parametric and suspected glaucoma, OCTA, based on their report, said that OCTA is useful. The degree of vessel density loss correlates significantly with severity. So degree and severity, those two things, OCTA can really kind of tease out. We're learning more about choroidal or deep layer microvascular dropout. Choroidal microvascular dropout is associated with glaucoma damage. We've not really even scratched the surface as it relates to looking deeper in the choroid. I know we're going to be doing a talk at the Academy this year looking at the deeper layers, including the choroid and the lamina, and so I hope that you're able to attend that at the Academy. But point being is, when it comes to the choroid, there's some emerging information that says that might be where we need to be looking in the management of glaucoma. And finally, we're going to find faster rates of disease progression. So we're going to see progression on OCTA in a slightly different way than we see on conventional OCT, and that might be really, really valuable. So again, these are conclusions from the Academy of Ophthalmology 3 years ago, not 6 months ago, not 3 months ago, 3 years ago, and there's a ton of data to support it since then. Now, again, to be fair, what is the bad? And their conclusion was that there were a whole lot of studies that OCTA said OCTA is really, really important from differentiating glaucomatous from healthy eyes. But there were some studies found that structural OCT measurements perform better. Why? Why is that? Well, the reason, and this is really, the ugly, and, we're referencing one of the best Westerns of all time, but the ugly part of OCTA is artifacts and image quality. There's so much data being gathered when it comes to OCTA, much more than conventional OCT. And so that's why first generation devices struggled a little bit, and current continue to struggle. But the Solix is not a first generation OCTA instrument. I would consider it more of a second generation. So a lot of the issues with artifacts and image quality go away with the Solix. And there's not any other companies that could say that at this stage. But to be fair, artifacts and image quality are a concern with OCTA, but much less of a concern with the Solix. Lack of longitudinal data, it's a newer technology. It's not new technology, but it's newer technology, and so we don't have quite as much longitudinal data at this point. So I hope that was, kind of a fair assessment of a summary. And again, this is from the AAO, and again, this was 3 years ago, and there's a ton of data that supports their conclusions from that study. Here's a study by Weinreb's group from 2022 that said OCTA may be more helpful than OCT in determining fast progressors. This is one of those studies that really builds on the AAO's conclusion, and they said the association was stronger for the OCTA model than for the OCT model, and I've got some cases that will help illustrate that. Now, again, choroidal microvascular dropout, not to be confused with beauty school dropout, but choroidal microvascular dropout, what is it? It's, again, looking at the choroid. We're looking at the choroid here in this area in yellow, adjacent to the optic nerve head. This dark area, looking deeper into the choroid, you can see it's just dark. So there is no blood supply. So looking at that particular area, and here's a couple of other studies. Here's choroidal microvascular dropout right in this area. So this dark area adjacent to the optic nerve, kind of like a beta zone that we've heard about in the past, kind of right in this area is not getting blood flow, and that's really important. We're finding in the management of glaucoma, and you can kind of see that visual field defect that it approaches fixation. Very, very concerning in terms of that particular patient. One of the most difficult challenges we have in the management of glaucoma is trying to parse out whether or not high myopes is this stretching just myopic stretching, or is it myopic stretching and glaucoma? It can be a real challenge looking at that. And so this comes from a presentation that we did at the Academy, I think it was 2 years ago, maybe last year, where we looked at these choroidal microvascular dropouts in high myopia. And this was a study from 2000 that found they had two groups of patients who were myopic with no glaucoma and patients who were myopic with glaucoma, and they found microvascular dropouts. This would be an example, kind of here and here in almost 100% of those eyes, 100% of those eyes. So they would contend, based on that study and several studies since, that choroidal microvascular dropout is a great way of distinguishing glaucoma in these high myopes, which again can be a huge, huge challenge. So Captain Kirk says, there is no such thing as the unknown, only things temporarily hidden. So we're just, scratching the surface in our understanding of how glaucoma and OCTA kind of exist together, and how we can use OCTA to our advantage in the management of glaucoma. I have a YouTube page called ODcoder, and so I'm just going to briefly talk about the 92133 code, scanning ophthalmic imaging of the optic nerve. We know that as of today, there is no code for OCTA as it relates to glaucoma, optic nerve, or retina, 92134 as well. But what we're hearing is that there's soon, what I'm hearing is there's soon going to be an OCTA code. We don't know when, we don't know the reimbursement, but finally it seems like Medicare is getting on board with OCTA, and so that obviously is going to be an exciting thing. But looking at it as of today, 92133 in central Pennsylvania, that is what the reimbursement is. Really important when you're doing OCT or OCTA, that to do a written order and report. So important to do both an order and report. If you don't have those two things, you're not going going to survive an audit. And it's a bilateral procedure. If you do it unilateral, you should do the modifier RT or LT with the 52 modifiers indicating reduced services. Kind of a newer regulation is you can do it 2 times a year for all glaucoma severities. You may remember hearing at some point that for advanced glaucoma, you can't even do OCT, nerve OCT. That has gone by the wayside now, and you can do it twice a year, whether you're a suspect or whether it's mild, moderate, or severe glaucoma. Literally hundreds of pathologies for the 92133. I put an asterisk around visual distortion of shape and size. That is one code that virtually, all these different procedure codes, diagnostic procedure codes will be reimbursed for, and it is mutually exclusive with 92250. And so not a great idea to bill 92250 and 92133. There are times where it may be indicated, but I think if you do it too often, you are at risk for audit. So on ODcoder, on my YouTube page, I have videos for many different procedures, and about every 2 or 3 weeks, I'll post a new video. So if you want to, follow that and get alerts when I post new videos, feel free to, to follow my ODcoder page. Now, moving into advanced glaucoma, we've talked about the importance of when you hit the floor with GCC and nerve fiber layer, how are you going to manage it? Well, currently we're going to do visual fields. Maybe we'll do a 24-2, maybe we'll do a 10-2. But very difficult, based on reproducibility. So give me something in the more advanced types of glaucoma, and that will make me happy. So how low can you go? Kind of what I'm illustrating here is that and this was a Weinreb Zangwill study in 2019, and they showed that the ganglion cell complex hits the floor at about -14 decibels on the visual field. And so we're getting into more advanced glaucomas, but nerve fiber layer hits the floor at -17. So what do you do in a -18 or a -19 patient? And how are you going to manage those? Well, again, most of the time we go to visual fields, but now with OCTA, we can go even deeper. And so parapapillary vessel density, so the vessel density around the optic nerve can go up to -19. And then the paramacular vessel density goes all the way to -25. So when you run out of room here, you still have room left to help manage advanced glaucoma, which can be a real challenge managing those by visual fields alone. To illustrate my point, here is an advanced glaucoma patient where we have hit the floor both in ganglion cell complex, you can see the floor is right here, and nerve fiber layer, the floor is right here. So it's not going to be a big benefit running OCTs, conventional OCTs on these patients. And you can kind of get a better sense of it here through this magnified view. However, now with using OCTA and the parapapillary scans and the paramacular scans, we now have a much lower floor. So we can continue with confidence, continue to scan these patients and looking for subtle changes in these patients. So we have quite a bit of room both in the parapapillary area and the paramacular area, because that floor is even lower. All right, I also want better progression. Give me better progression with these patients. And so here's an example of a patient that I've been able to watch over the last 2 years. Good stability in nerve fiber layer and ganglion cell complex. So I'm happy about that. I can also again manage this patient by looking at parapapillary OCTA and paramacular OCTA. So I feel really comfortable knowing all 4 of those parameters are nice and stable. So again, much more valuable than just traditional OCT, nerve fiber layer and ganglion cell complex. And the reason that I'm getting better progression analysis through my Solix is because of better repeatability and reproducibility. And so here's an example. On my previous version from Visionix, the Avante, the resolution was about 2.2 microns. My Solix has microns of 0.7, so really an impressive jump. And so to see progression, and these are two patients, a representation of two patients with the same amount of progression based on the repeatability and reproducibility, it's going to take me greater than 1.5 years to really see that type of progression. However, with the better resolution, I can now pick up significant progression in about half the time, in about 0.75 years. So as we get better with resolution, we're able to have better glaucoma progression, more valuable glaucoma progression. So here's a clinical example, a practical example where I was looking at this patient. This is over a year using my Avante instrument, really a great instrument. In the right eye, I'm looking at the nerve fiber layer and ganglion cell complex. My confidence intervals are not as good as I would like. With that said, it's kind of giving me a flat slope in the right eye, and in the left eye, it's also giving me a flat slope with much better confidence intervals. So I'd look at that and I would say, okay, over the course of a year, I'm not too concerned. We're going to keep this patient on the same treatment. The exact same patient, we took a measurement, we took a scan on the Solix, 6 months ago. And so not only because of better resolution, am I going to get more accurate data based on the reference database. For example, my previous unit is saying, from a ganglion cell complex standpoint, from here to here, that could be significant. But at the follow-up visit, it's like, oh wow, okay, so maybe I don't really need to be worried about that. But yet on my Solix, this just kind of jumps right out at me, and as does this. So this looks much more suspicious to me than this does. When I also look at the vessel density difference, and I look at this, it's like, wow, yeah, no, that's definitely a nerve fiber layer defect, which we can also see on the ENFOS image. But and then if we parse it out, 32 versus 37, that's significant in terms of the vessel density asymmetry. So from just based on that alone, I'm much more suspicious, much more concerning. But again, this is over a year in the left eye, and this is based on 6 months, 6-month difference on the Solix instrument. And you could already see there is a trend over 6 months, a declining trend that's not being picked up on a year over my previous instrument. And so I want better progression analysis, and that's exactly what I'm getting here. Here's an interesting study that looked at OCTA, foveal avascular zone, and glaucoma. We know how important the foveal avascular zone is in the measure using OCTA when monitoring diabetic patients. And as they get worse as time goes by from a diabetic and retinopathy standpoint, the FAZ increases. But is there a role of FAZ in glaucoma? Weinreb's group in 2022 followed a group of patients that had surgery for glaucoma, and the FAZ actually decreased. And so starting to ask ourselves, can we use FAZ in the management of glaucoma? And Weinreb's group is putting out some research that says, hey, we need to pay attention to this pretty carefully. And so in this study, it showed the non-surgery group, as time goes by, there was really no change in FAZ, but glaucoma surgery alone decreased in size, and then glaucoma surgery combined with cataract surgery decreased even further. And again, these are FAZ both pre and post, and we can see this how much smaller the FAZ. We can just eyeball that in this case as well. So FAZ is something I'm really starting to pay attention to in my glaucoma patients. Here's another study that looked at OCTA macular vessel density in glaucoma. And in this particular study, also Weinred's group in 2020, that followed eyes and in glaucoma, the macular vessel density decrease in patients that had surgery over a 3-month visit. The macular vessel density decrease was faster than GCC thinning and associated with the severity of disease. I'm sorry, these patients did not have surgery. These patients were just being followed for progression, and they found macular vessel density decrease faster than GCC thinning. And so this is not to say that OCTA is superior to conventional OCT. In many ways, they're complementary to each other, and having both at your fingertips can really help out in glaucoma management. And then, is blood flow in glaucoma reversible? Is it reversible? I borrowed this slide from Drew Rickson from Memphis, who we've had a chance to work together closely over the last couple Academy meeting lectures. And what he found was, here was a study from 2018 that found that reversibility with vessel density. And patients that were treated with certain medications improved vessel density, improved perfusion. And so are we at the point now where we can more comprehensively tell a patient, once we put them on a treatment, hey, you're actually improving based on our treatment, more than just looking at pressures and hoping that we're reducing stress on the optic nerve, actually seeing true objective evidence of improvement, perfusion improvement. Now, final thing is the final point that I would like to make about the Solix is anterior segment imaging. And we all know what it's like with some of our current OCT units, where we're imaging just a small part of the angle, and that can be helpful. That can be helpful. But having edge to edge, I can't tell you how much that has enhanced my understanding of angle mechanics and iris configuration. So having the whole edge to edge and really appreciating iris configuration has been a game changer for me. And so this is what we're used to. We're used to imaging just small sections, and again, that can be helpful, but having edge to edge is really important. I'm going to illustrate that with a case. And this was published in a review of optometry not that long ago, so you can dive in more. We go into much more detail than we can this evening. So we have a 60-year-old Hispanic male who came in with mild changes in his near vision, best corrected 20/20, +2, just mildly hyperopic. His last exam was 2 years ago. His intraocular pressure using a screening NCT was 14. He only has grade 1 nuclear sclerosis, glare test, very little glare there. And so we look at him by Van Erich, and we find really narrow. But how narrow? So we throw him on the Solix, and we can see edge to edge, and just look at how dangerous that looks. Look at how close that is. It's amazing to me that his pressure was only 14. Like, how is that not a pressure of 60 or 70? How is he not in immediate angle closure? So we consulted with our in-house ophthalmologist, fellowship trained in glaucoma, and we said, really, we should be considering cataract surgery here. But according to the Eagle study, these patients had glaucoma, glaucomatous optic, glaucomatous changes, glaucomatous optic neuropathy, and so this patient did not. He was completely clear of all those things. So we had a decision to make. Should we go directly to cataract surgery, or should we do a laser PI? And just because it would have taken us probably 6 to 8 weeks to get him in for the cataract surgery to actually have it done, we decided to do a PI, probably that week. And so we go ahead and did a PI. Here is the baseline. Here is post LPI. And we can see what we did make an improvement. So we opened it up slightly, not as much as I would have liked, but we did open him up slightly. So then we kind of monitored him. 6 months later, he came in. He glare tested to something like 2050 or 2060 at that point. So we said at that point, hey, let's go ahead and perform cataract surgery. So we can see here baseline, post LPI with a little bit of improvement, and now post cataract surgery, and now that angle is open. And at this point, I'm not concerned about this patient anymore. This patient will not close. Gonioscopy was important through all of these different stages, but having edge-to-edge angle scans and being able to appreciate it really helped out. How many times have you had discussions with patients about the importance of an LPI, and they really have difficulty conceptualizing it. But with these angle-to-angle scans, it makes my job much easier to convince them the importance of doing LPI. Again, the 14-year ZAP study tells us we don't really need to do as many LPIs, and I think that's true. But in those cases that we want to, like in this particular case, it really helps us convincing those patients of the need. So I'm going to kind of skip over that, and I'm going to end the lecture part of the conversation. But at this point, I am more than happy to address questions.
All right, well, thank you, Mike. That was really great. And we do have a bunch of questions. And everyone, remember, if you have any questions on the right side of the screen, feel free to type questions into that box, and we will try to get them all answered. And so let's see. Question here. First question, you mentioned the Avanti before. I don't know if you have time to actually do this. Can you go over the differences between the two units?
Yeah, and I would say this: they both have angio, and they both are amazing glaucoma tools. Like, we used our Avanti for years, and probably, I want to say 6 or 7 years prior to our Solix, and it's a great instrument, and I'm so appreciative of it. And it was the first unit that gave me OCT-A, so it really allowed me to expand into this space. But one of the weaknesses of Avanti, as it relates to OCTA, was it's not as quick as a scanning speed as Solix. Solix has a much quicker scanning speed. So for our older patients, you want to have as quick of a scanning speed as possible. And so the Solix not only scans much more quickly, so it's your technicians are much happier with you, but also the resolution difference going from roughly 2.2 microns on the Avanti to 0.7 microns on the Solix. Those are the main differences between those two. And the Solix gives me edge to edge. The Avanti did not. There are a couple other nuances that we can go into with the Solix, but basically that's the difference.
Right, and I guess this was sort of a follow-up question. The workflow in your office, you've obviously had OCTA, previously, right, with the Avanti unit as well. What's it like in your office? Do you actually do the scans yourself, or do you always hand that off to a tech?
Yeah, so I never do any of the scans myself. I'm not sure I could turn the instrument on, but so we have amazing techs to do all of those things. And again, they, having an instrument like the Solix, when they come to me and say, "Yo, yeah, this is significantly better than previous generations technology in terms of ease of use," then that certainly makes me happy.
Right. A really good technical question here. Are there normative values for vessel density? So for example, at what value do we become concerned? And can we categorize values as early, moderate, or severe loss just based on a numerical value?
Yeah, that's a very sophisticated question, and I appreciate it. So we know that with nerve fiber layer and ganglion cell complex, we have normative database. So we can look at those thicknesses and say, according to, compared to normals, is this patient that may or may have glaucoma, are they outside of those ranges with GCC and nerve fiber layer? We do not have that yet for OCTA. So we have metrics and we can see those numbers, but we can't What I can tell you is based on my experience, I have a pretty good sense of normals and those numbers on metrics where they're going to fall out, but we don't yet have a database that we can use for vessel density. So thank you for that question.
Right, and I kind of wondered, with the increased uptake of OCTA over the past, say, 3 or 4 years even, if that database will eventually become available, right? If there's going to be so much data out there, if manufacturers like Visionix can't actually produce something.
Yeah, you raise a really good point, and what I would say is, like, gosh, we're talking about glaucoma and OCTA. I can talk to you for hours about the importance of OCTA in diabetes and hypertensive retinopathy and all those things. So it's so fun that we're now getting into the glaucoma space. And so my hope is that, at some point in the near future, we're going to have reference databases for OCTA. And I think as scanning speeds improve and we get more sophisticated, it's only a matter of time before we're going to be able to do that.
Right. And interesting question here about resolution. And I guess I'll make it a more generic question. I don't know if you've actually been exposed to the breadth of the market of OCTA units out there, but talking about resolution, how has it changed over time, and what are you seeing? Obviously with Visionix, you have the Solix, and you know that unit intimately, but has the resolution been improving over the past few years?
Yeah, I would say that based on my experience with Avante and how that is changed with the Solix, having the faster scanning speeds, I'm getting much more reliable data, much more reproducible data. And so I don't actually know the answer on whether or not the resolution has improved. But what I can tell you, practically speaking, the scans themselves have improved in a big way, going from previous generation to Solix.
Right, yeah, because there's another question here actually about patient compliance, because they said they had a very old unit, one of the first generation OCTAs, which was great, but it was very difficult for the patients because the scans took, however long it was, a minute, 2 minutes, whatever it was. Yep. And so you're finding that's actually much shorter now.
Yeah, so much shorter. So, probably with my previous generation OCTA, I could scan maybe, 50 to 60% of all patients that could do a nerve fiber layer in GCC. I could also scan them on OCTA. Now that number is probably 85 to 90%. There's still, maybe 10% of my patients that I'm not going to be able to get a good OCTA on, and that's, that's okay for various reasons. But that percentage now is huge with the Solix.
Right. Interesting practice management question here. Are there any billable diagnostic codes for an anterior seg OCT for checking the angles?
Yeah, there is. It's 92132, and that can be billed up to twice a year. You have to be a little careful with the diagnostic codes. So, low risk glaucoma suspect, you cannot use that code when you're building anterior segment. It has to be high risk code or one of the narrow angle codes. If you want more information, you really definitely should go to my YouTube page, because I talk about that particular procedure in great detail.
Great, and we'll actually put a link to your YouTube channel where the archive of this video is going to live on ODwire, and we'll put it right beneath it so
Thanks.
People can get directly to the channel.
Thank you.
Sure. And question here, I don't think this one's for you probably, but it's a question on pricing. Roughly how much does the Solix cost, give or take?
Yeah, that's out of my realm.
So I don't know if anyone at Visionix wants to tackle it. I think I know what the answer is. I can almost recite it now, that you have to ask your rep. Am I right?
Yeah. So Adam, if they just go to like Visionix.com/US/ODwire, they can fill out a form and we can get them in contact with their rep. It really all does vary based off of, what we have going on. We've got View coming around the corner. We'll be there and we're going to have some great specials, hopefully get to preview some new things coming down the pipe, so you guys will get to see that. And then we have some trade-in deals, so depending on what you're trading in, obviously that affects your price as well. So the best way to know based off your case is to just, go online, fill out a form, and my team will get you connected to your rep.
Excellent, and I'll put up the link. We have our own little special ODwire landing page, as you alluded to, so I'll put the link to that right beneath the show as well when the archive goes up, so people can get to it quickly. And I guess one follow-up question would be about the training. So, Mike, of course, you mentioned that you wouldn't even know how to turn it on, but clearly your techs do.
Yes.
And so, how did that actually happen? What's the process of getting onboarded?
Yeah, so at the time, we had amazing training, in-person training. I don't know, whether or not it's still in-person training, but OCTA was a little different animal for us, and I know Visionix was great in training our technicians to really kind of be comfortable with it, and we were able to hit the ground running.
Great. All right, well, it actually looks like we have hit the 1 hour mark. So Mike, I want to thank you for being here and sharing all this with us today. And thank you everyone for showing up here tonight. And this archive will be available on ODwire within the next 2 to 3 days. And you'll be getting a follow-up email all about it. So don't worry if you missed anything, if you want to look at the slides again, they'll all be there for you to look at. So Mike, thanks again for being here.
Thank you, Adam, for hosting and moderating this, and thank you to Rachel and Ciara and everyone at Visionix for giving me the platform.
Absolutely. Well, thanks so much, and I guess I'll see everyone online. Good night, everyone.